After nerve injuries, the second important chapter is arthritis. And in trauma, upper limb trauma also is very, very important. So let's talk about trauma and upper limb trauma. Fracture. What is a fracture? Fracture is a microscopic or macroscopic break in the continuity of the cortex. It is not defined with the bone word, it is defined with the cortex. When we look at traumatic situations and we look at the ATLS guidelines, they clearly say it's always airway, then breathing, then circulation. That's how you assess a patient. But stabilize the cervical spine first. This is ATLS guidelines. And when we come back to trauma fractures, sure sign of a fracture, abnormal mobility. Joints are normally mobile. But when there's a mobility in between the limb, that's abnormal mobility. Or failure to transmit the movement proximally. If I rotate my hand, my forearm and elbow, the movement goes proximally. When it does not go because of the fracture site, the movement will occur at the fracture site. It means the same as abnormal mobility, but defined as a second point. Third, although not the classical feature, but given in some textbooks, crepitus. Crepitus is sound produced by rubbing of the bone ends. Should never be elicited, can cause neurogenic shock, only to be answered if the first two are not there. Most consistent sign, tenderness. Not all the fractures might have abnormal mobility. Like the fractures which are impacted into each other will not have abnormal mobility, but will have tenderness, the commonest or the consistent sign. Commonest fractures. Overall, clavicle. At birth, clavicle. Children, forearm, and if you have to choose in between the two, radius more than ulna. Commonest joint to dislocate, shoulder, anteriorly. So shoulder goes anterior, all other joints usually go posterior, like elbow posterior, wrist posterior, hip posterior, knee posterior. So they usually go posterior. Dislocation in children, elbow. I just told you, posterior. Rarest joint to dislocate, ankle. Since ankle is the rarest joint to dislocate, it is the commonest area where the ligamentous injuries are seen because the force on the joint is dissipated into soft tissues. The ligament injury is called as a sprain, and anterior talofibular ligament is the commonest ligament injured around ankle. Sometimes in the question they ask you the medial ligament damage around the ankle, that's deltoid. They will give you a question. Patient had injury around ankle, swelling around the medium malleus, X-ray is normal. What has got damage? Deltoid ligament. Then the commonest tendon injury in human body. It is supraspinatus around shoulder, followed by biceps, followed by tendoachilles. Your books mention tendoachilles as number 1. It's number 3rd. When there is a bone formation going on, there are some markers which rise in the blood and urine, like osteocalcin, alkaline phosphatase. These two markers are very important for bone formation. Serum procollagen type 1 and C is another one you should remember for the list. But what is more commonly asked is markers of resorption. Number 1, hydroxyproline. Nowadays, they are also asking you pyridinoline, deoxypyridinoline, and telopeptides. So when bone formation disorders are there, osteocalcin ALP, bone resorption disorders are there, the markers of resorption like hydroxyproline, when both formation and resorption are high, means the bone turnover is high, then you have a disease in which all the markers are high. Remember the classical name, Paget's, also called as osteitis deformans. Stages of fracture healing. If there is a fracture, there will be blood around it. This blood is important source of nutrients and cells for the bone to unite. It's called as fracture hematoma. Very important. If the hematoma is inside the skin, it's a closed fracture. If there's a rent in the skin and soft tissues and hematoma comes out, it's an open fracture. The bone ends need not come out. Even if the hematoma comes out, it means the same. So, all your treatments, which are advanced nowadays, have gone to the basic principle: preserve the hematoma. That's how the closed methods of treatment and reduction are there, in which the hematoma is not exposed to the environment. In open reductions, it's exposed. On this hematoma, the neovascularization occurs, the granulation tissue, over which the immature bone or callus or soft callus forms. Callus is deformable but not displaceable. It is the earliest radiological feature that the bone has started uniting, seen around 3 weeks. Then over it, the hard callus or consolidation occurs, where the mobility is lost. The fracture starts to unite. And then over that, the remodeling will occur, where the osteoclasts also have a role to play. You won't come to know where actually the fracture took place. It takes place over years. This is soft callus, seen at 3 weeks. Callus, again, seen at 3 weeks. Important. Let's look at this fracture, supracondylar fracture humerus. It's an extra-articular fracture. There is hematoma here. What do? You reduce it and make a small incision around the elbow, put it inside. You don't expose the hematoma. That's why this is a close reduction and fixation, because you did not expose the fracture hematoma. Extra-articular injury means away from the joint, close reduced. That's how you do it. Take the patient to operation theatre, give anesthesia, apply traction, check under the C-arm or image intensifier the reduction is satisfactory or not, and under the X-ray control, put the wire. Close reduction, internal fixation. Compare it to this image. Here, the fracture occurs through the joint surface. Your aim is to restore the joint surface. You will open it, perfectly reduce it like a jigsaw puzzle, fix it. Here you're not worried about the irregularity. You're worried about that if there's an irregularity, it will in future lead to arthritis. Even if you lose hematoma, don't worry. You have to finally achieve a smooth surface like a pearl. So, intra-articular fractures, open reduction. Losing hematoma, not a concern. So when you have fracture healing, what you just did, the stages of fracture healing, the hematoma, the granulation tissue, the callus, the consolidation and remodeling, this is called as secondary healing. There is callus and it's a biological stage. You can see the word C in it. It means there is callus formation. It also means this is the healing stage you achieve in cast. In the spelling you also have the word N, means nailing. Why will a callus form? Why will secondary healing occur? Because at the fracture site there is microscopic movement. Macroscopic movement will not allow the union, non-union. Microscopic movement trigger the biology, callus formation, bone unites. So if there is some movement, it helps in union. Many a times it happens. A patient with a head injury unites earlier because they have uncontrolled involuntary movement in the fracture site, helping in the callus formation and union. So this is secondary healing. In the spelling there's a C. So in callus formation, cast application. In the spelling of secondary you have an N, so nailing. But when you expose the fracture, you fix that, reduce it well, apply a plate with a screw, jam pack it, no movement occurs. This is primary healing. Primary healing, no movement. So callus is absent, non-biological. Directly the bone will unite. In primary there is no C, callus not there. In primary spelling there is no N, so no nailing, no cast. Primary there is a P. It means in plating you have primary healing. Now in the spelling of secondary there is no P. So plating, there is no secondary healing. Remember this. When the fracture does not unite at the end of 9 months, it's labeled as non-union. In these 9 months, last 3 months, there is no further progress in the stages of healing. So this is non-union. Now, non-union can be two types. Number one, when there is a fracture damaging the vascularity, it's called as atrophic non-union. Second, when there is mobility at the fracture site, callus keeps on formatting but does not change to consolidation. It's called as hypertrophic non-union. So let's compare hypertrophic non-union or atrophic non-union. Atrophic is also called as avascular. Hypertrophic is also called as vascular. There is high amount of callus. There is no callus. Treatment, stabilize. Callus will change into consolidation and the bone will unite. Simple. Atrophic non-union, freshen the margins. You remember the paprika sign? Removing the dead bone till the bleeding surface comes? Fix it, that is stabilize it. Put a bone graft. Here, callus is there like a bone graft. Here there is no callus in atrophic, so put a bone graft. So this is how you treat. Many times the question comes, in hypertrophic non-union, what will you do? Stabilize. Atrophic, stabilize, fix and bone grafting. Remember the difference. Fractures known for non-union, remember by the mnemonic flutes. So the fractures known for non-union, remember by mnemonic flutes. F is femur neck. Neck of femur does not have the cambium layer, non-union. Lateral condyle humerus. This fracture will cause cubitus valgus. Ulna, tibia and talus and scaphoid. Dear friends, the most common complication of scaphoid is non-union. In your books, they are given avascular necrosis. Please correct it. Fractures known for malunion do not unite in optimum position. M for malunion. I, intertrochanteric fracture femur. S, supracondylar fracture humerus, and this is known for cubitus varus. Valgus, there is a lateral displacement of a distal limb. Varus, it comes towards the midline. And then C for Colles, which is known to produce dinner fork deformity, and C for clavicle. So these are the fractures known for malunion. So Gusklow-Anderson classification is for open fractures. One of the most common classification asked in entrance exam. Grade 1 open fracture is a wound less than 1 centimeter. There is no comminution, no contamination, no segmental fractures. Grade 2 is a wound more than 1 centimeter. Again, no comminution, no contamination. Grade 3 is a comminuted, contaminated, segmental fracture, gunshot injuries or farmhouse injuries. Grade 3A, it has a good skin coverage. So majority of your gunshot injuries have good skin coverage, 3A. 3B requires coverage because the periosteal stripping is there. Grade 3C, irrespective of the size of the wound, there is a vascular injury. Any open injury, the usual overall treatment is debridement plus external fixator. Although in stage 1 and 2, within first 6 hours, you can do internal fixation. But they don't talk to you about this. They talk about overall, so debrima plus external fixator.